Hello everyone, welcome back to the Orthopedic Tutor channel. Today we'll be discussing about the ulnar nerve compression neuropathy. Well, you can look at all these basic science that goes around the compression neuropathy over at my other video, which is called the compression neuropathy video. And today we are going to discuss one of the two types of the ulnar nerve compression neuropathy. So basically there are two sites where the ulnar nerve can be compressed. The first would be the ulnar tunnel, or also known as the Gion canal syndrome, and the other one would be the cubital tunnel syndrome. Well, today we'll be discussing this one, and the Gion canal syndrome will be discussed in the next video. So talking about the cubital tunnel syndrome, one needs to know the basic anatomy that is related to it, which is the cubital tunnel itself. Well, the cubital tunnel is formed by various areas that makes up its borders. As you can see here, that the cubital tunnel has a roof, floor and wall component. When you imagine at the cubital tunnel, which is situated over at the medial aspect of the elbow, you could readily palpate your own ulnar nerve there. So the roof, the ones that makes up its roof, is the FCU, or flexor carpi ulnaris fascia, and the os bone ligaments, and the ones that makes up the floor, which is also the base of the cubital tunnel, will be the MCL, or medial collateral ligament, and the elbow joint capsule. Well, the walls that forms up the cubital tunnel is made up of bony structures, which is the medial epicondyle and also the olecranon. Well, this is actually a very common type of compression neuropathy, being the second most common found in the upper extremity. It is also frequently associated with certain conditions such as elbow contracture, cubitus valgus or even varus, medial epicondylitis, and also burns. Well, the compression sites is definitely all around the elbow. You could see here that the most common site of compression would be around the two heads of FCU. This picture here clearly depicts the area of compression. You could see here as the ulnar nerve travels around the elbow, there are certain sites where the nerve may be compressed. The first would be around the arcade of stratus. These are openings at the medial intermuscular septum, and you could see here also around the medial elbow region there is the distal transverse fibers of the arcade of stratus, and also the os bone ligament, and most distally would be between the two heads of the flexor carpi ulnaris muscle. Now this is definitely the most common site, and this needs to be addressed when we plan on doing a decompression surgery. Next would be the other less common site. It could be entrapped over at the medial head of triceps, medial intermuscular septum, and so on. Well, most of them is caused by external compression, sometimes external soft tissue compression, sometimes the compression could come from bony structures, which may be caused by fracture, malunions, osteophytes, heterotropic ossifications, or even some other types of space-occupying lesion. Now here is another picture that shows the arcade of stratus, which arises around 8 cm proximal to the medial humeral epicondyle. So it goes way up here at the proximal. We could see here this is a medial intermuscular septum, the fibrous septum that goes in between the medial arm region, and you could see here as the ulnar nerve is going through this area, it is directly compressed or directly situated over the under surface of the arcade of stratus. Now the next thing we need to know is how to make a proper diagnosis, because these ulnar nerve symptoms, they can present in a wide range of symptoms. So you need to know all the basics that is regarding to the ulnar nerve function in order to make a good diagnosis. First, you need to know that when nerve is compressed, you could find sensory disturbances such as paresthesias. You could also see that the night symptoms may occur because while we are sleeping, our body assumes a certain posture of elbow flexion and wrist flexion. And this elbow flexion actually increase the tension that is being given on the ulnar nerve, and therefore the patient may present with night symptoms. Next would be around the physical findings. During the inspection phase, you can see atrophy. Atrophy is especially noticeable around the in between the metacarpal bones. We could see here that what makes up the muscles that makes up the uh, bulk of muscle in between the metacarpal would be the interosseous and also the lumbricals, and in here you could see that there is a interosseous wasting, loss of muscle belly all around here, and also the first web space atrophy, and you could see a clawing. We'll get to that in a moment later. You could see here that the finger forms a claw like lesion here. Okay, and next you could also palpate to feel whether or not the ulnar nerve can subluxate at the medial epicondyle during various angles of elbow flexion. While neurologically you could find disturbances of the ulnar nerve function, which includes a sensory deficit and also the motoric deficit. For the sensory deficit, you usually need to palpate all around the borders of the ring finger or the little fingers. Now, for motoric wise, you need to know that the ulnar nerve, they gives up innervation to several types of muscle. The muscles which are considered as intrinsic muscles are those muscles that originate and also inserts at the same area at the hand, which is around the metacarpals and the phalanx. And while the extrinsic muscle group is the muscles that are originating outside of the wrist and hand region, they go up way up from the forearm and they insert over at the hand region. Now the ulnar nerve, they definitely give innervation to both these two types of muscle. So we'll go on first at evaluating the extrinsic weakness. One of the tests that I really like to do is the Pollock's test. The Pollock's test, they basically just ask the patient, we basically ask the patient by flexing the distal interphalangeal joint of the small finger, and the inability to do so is usually associated with a low ulnar nerve palsy. You should remember that while you want to test the distal interphalangeal joint, you need to fixate their proximal interphalangeal joint, or else other types of muscle would be activated. And so after I do a Pollock test to confirm a extrinsic weakness, I usually continue on with doing a physical exam to determine any intrinsic weakness. Now, intrinsic weakness is very interesting because a lot of muscle is there in the hand, and so there are many types of physical exam of tests that could be done to detect whether or not there is a intrinsic weakness, and it includes weak grasping, weak pinching, Frohman sign, Jean sign, Wartenberg sign, and even Mass sign. And one of the the easiest one I found is the Frohman sign and also the Jean sign. You could see here that you can basically just ask the patient to pinch something, and the ability of the patient to use their whole fingers to pinch it using their interosseous muscles and also the interosseous muscles here, they try to activate the flexor muscles, and we could see here that the IP joint goes into a hyperflexion position. Now this is called the Frohman sign, and this type of abnormalities followed by the inability of followed by the hyperextension over the metacarpophalangeal joint. Okay, this joint here goes into a hyperextension due to the instability of muscle power that goes around it, and also laxity of the volar plate, which keeps the joint from going into a hyperextended position. So the combination of that pathology makes the patient has a positive gene sign, which shows that the MP joint goes into hyperextension. So just by asking the patient to pinch something, you could already detect two types of sign. And then the next would be the Duchenne sign. Duchenne sign would show you this picture here: hyperextension of the MP joint and also flexion of the IP joints of the ring and small finger, or basically just showing you that there is a clawing deformity over at the ulnar two fingers. The last one would be the Bovia maneuver, which you could do. You could just prevent the MP joint from going into hyperextension, as you can see here. So you block those movements using your finger, and then you allow the extrinsic extensors to extend the IP joint. Now this type of maneuver allows you to assess, I'm going to show you this table here, okay? So this allows you to assess this the function of the extrinsic extensors muscles, because when you do the Bovia maneuver and if the fingers are able to extend, then the extrinsic extensors are still good. And next, these are all other names and types of tests and sign that you could do, and also the other maneuvers, but it's best that you just pick several type of tests that are comfortable to use and easier to apply during your clinical practice, so you do not get lost with all these names. Now the next examination that you could do to assess the ulnar nerve compression neuropathy is the EMG-NCV. Well, as you have known that the EMG-NCV allows you to detect the localization of the lesion, and also the changes that occur around the muscle function and also the nerve conduction. When with this examination, you could see that the conduction velocity will significantly decrease to reach a value of under 50 meter per second. And next would be the management plan. Well, as we all know, all cases should be managed non-operatively if possible, and that should include the drugs, the NSAIDs drugs, and also the activity modification along with nighttime elbow extension splinting. As you might have guessed that this type of splinting is good if the patient indeed has night symptoms, such as those found in the carpal tunnel, where patients may complain of night pain when their wrist goes into flexion. Now, the next thing you need to know is that for the operative procedure, there are generally several types of things you could do, starting from the basic ulnar nerve decompression along with transposition of the ulnar nerve to the anterior aspect of the humerus, and you could also do procedures such as ulnar nerve decompression along with bone osteotomy or epicondylectomy. Now the thing about it is that you need to do the least invasive one first, or the procedure that changes the least amount of body structures. Now, the ulnar nerve decompression is usually indicated when the non-operative treatment has failed, and it is usually done before any denervation is found. Now, for the ulnar nerve decompression, you could do it with open surgery or endoscopic surgery. For the ulnar nerve decompression and transposition, you only need to do it when you have found a failed case where you have performed a decompression but the symptoms still persist, and you need to do it on certain cases of throwing athletes, and you also need to do it when you found a bony abnormality, which could come from tumor, osteophyte, or heterotrophic bone. The position in which you could place the nerve is under the skin, under the muscle, or even within the muscle, which is once again situated over at the anterior aspect of the elbow. Next would be the ulnar nerve decompression and medial epicondylectomy. You only need to do bony osteotomy here when you could visibly see, and also there is a symptomatic subluxation of the nerve. So this is in only a very specific population of patients. Next would be the claw hand operation or correction. You need to know that you do these types of operation as a salvage type of operation. So the condition has become so severe that claw hand has indeed formed, and this clawing can be corrected using static procedures and also dynamic procedures. Well, what we call as a static procedure is only indicated when you have positive Bovia test, and usually you also sometimes perform a more proximal action procedure. And the techniques for the static is that you do not change anything for the tendon function or the muscle function. You just need to do something that is static, and in this case you do tenodesis and also capsuloplasties around the hand joint capsules. And the next would be dynamic procedures. So you could do dynamic procedures to help to actually redirect the pull of muscles around the hand, and these are called the dynamic procedures. And you could correct the hand function based on the location of your action, which could be proximal action, the distal action, or the lasso technique or direct interosseous activation. For the proximal action, it corrects only the MP flexion, and for the distal action, you correct the MP flexion and also IP extension. And these are indicated when you have negative Bovia test and also possible passive IP extension. The discussion on the techniques of this claw hand correction is actually very deep, and you need to read a lot to be able to understand how and what types of muscle tendon redirection could help you achieve the correction of a claw hand. I suggest you do some research and look for the journals that are publicated. Usually several hand surgeons out there would make their own publication on the regime or the pathway for treatment and identifying a claw hand deformity and how to treat them. Now, the next would be the post-management program. So as you have known that the cubital tunnel syndrome is also associated with certain complications such as recurrence or even neuroma formation when the nerve is irritated while you do the surgery. And what other things could occur is that you need to know the poor prognosis, which usually happens with signs of intrinsic muscle atrophy. So when you find this in a patient who came to your clinic, you need to educate them that the prognosis of the things that you do might not be as well as they had hoped for. For the conservative treatment plan, usually it is effective in around 50% of cases. Well, I guess that is all for today's discussion regarding the cubital tunnel syndrome. For more discussion and also the comparison between this type of syndrome and the other syndrome, which is the Gion canal syndrome, check out the second part of this video, which is the ulnar nerve compression neuropathy part 2. Thank you, and please subscribe for more videos at the Orthopedic Tutor channel.